She is an acute care nurse practitioner and manages stroke patients in discharge unit. She's the program director at the University of Maryland's Medical Center Comprehensive Stroke Center. She's responsible for regulatory and performance improvement activities at the center. She was a previous reviewer for the Joint Commission and has reviewed comprehensive stroke centers. And she recently earned her Doctor of Nursing practice at the University of Maryland School of Nursing. Please join me in welcoming Dr. Yarbrough today. Thank you.
Thank you very much. I really did thought I was going to be the oldest person earning my doctorate, but I wasn't, and I was able to get through it. And there are two people here I really want to just recognize briefly. One of my mentors in nursing and who I've really have gotten encouragement from for the last 20 years is Moonyin Klopfenstein. I think you probably all know her, but without her guidance in my career, I don't think I would have earned my doctorate. So she doesn't know how much I really care about her, sort of like a third cousin twice removed. I do love her very much. So I want to thank you. And then also Jennifer is here. She's going to be one of our speakers today, talking about stroke depression and fatigue, which was one of my areas of interest when I was earning my doctorate. So I'm really excited to have them both here. I also want you to know that when I know there's a camera running, I'm like a deer in the headlights. So please forgive me if I'm nervous during this presentation because I really do not like the idea of the camera running. But what I'm going to talk about today really is the triage of complex stroke patients. What I was really going to talk about is the reality-based standards and interventions that as primary and comprehensive stroke centers, we need to collaboratively put into place so we can get that right patient to the right place at the right time. But I'm also going to talk about the national challenges that we're seeing, and maybe not so much in Delaware, but I know in Philadelphia and Maryland. And in preparation for today, I am usually socially awkward, but I called at least 50 stroke centers to ask them what their practices were so I could share with you some of their best practices. I have no financial disclosures to report, but I always wish I had, but I don't. I do have some things hidden in my closet for Christmas my husband is not yet aware of. I got started last week, and that's always a big deal in my house. So what am I going to do today? I'm really going to briefly discuss the historical development of primary and comprehensive stroke centers. I think it's important for us to understand that the problems that we are having now with transferring patients from primary to comprehensive are the exact same issues we had when my hair was really blonde. And so these are some of the same issues we're dealing with. What I'm learning is that the translation of practice and the translation of research and practice can no longer take 17 years. We need to work quickly and we need to change practice and change culture. So I'm going to talk about that. I'm really going to discuss the clinical manifestations of that complex stroke patient. How do we define it? Every single patient who arrives at the primary stroke center is not a candidate to be transferred to the comprehensive stroke center. And I'm going to talk to you about reality-based decisions of who and what patients should be transferred to a comprehensive stroke center. I'm really going to concentrate on that patient with a large vessel occlusion, because that's really what everyone is talking about on the listservs. That's the controversy we're seeing with our ED physicians as well as our community neurologists. So there was a great pooled analysis that was just published not long ago that really talks about the reality of that providing IA therapies for stroke patients is standard of care. And that's something that we need to acknowledge across the country. So it's no longer an investigational procedure, but it's actually a standard of care for our patients. And then I'm going to talk about really our experiences in the Mid-Atlantic region with strategies and challenges for interfacility transfer. I just want to tell you, I just got a call from my regulatory officer that my institution has the longest decision to arrival time. So I'm going to share that information with you as well. So back in the day in 1996, when I first started taking care of stroke patients, TPA came out. Everyone was so excited, and we were absolutely sure every ED doctor across the nation was going to be so excited about giving this drug. Far from the course. Even as recently as 3 years ago, some of the professional organizations are saying we're not necessarily obligated to give this drug. Although it's recommended, we're not obligated. I work with Dr. John Cole, and his wife is a malpractice lawyer, so she comes and speaks to us once in a while. And the lawsuits that are occurring are actually occurring to ED physicians, community neurologists, and nurses in the ED who will not provide the IV TPA administration, or at least assessing the patient to see whether or not they meet criteria. So that was back in the day. I was around during this whole process, and really stroke systems of care did not exist. I worked at the University of Maryland at the time. We had a 4-bed stroke unit. It was hidden away on the 4th floor. We lined them all up. They all died. They all died of pneumonia. They all died of malignant edema. They all died because we just did not know what to do with them back in the day. And then TPA came around. Then the Brain Attack Coalition came around, which is a very powerful consensus of intellectuals who said, this is not right. We now have a first-line treatment that's FDA approved in which we can provide stroke patients. And this is sort of like, I'm dating myself, the water buffalo that Fred Flintstone went to. These were the gurus of stroke who really knew what they were talking about, and they made recommendations for the metrics for brain attack centers. So that's when we started to develop across the country acute stroke teams that really treated stroke as an emergency. And I can tell you right now across the nation, we are not all treating stroke patients like a trauma and like a STEMI, and we can talk about that. We had to have written protocols at the time. If you remember, if you were around, we had care paths, pathways that we had to complete. You really did have to have a base station in the ED so that the EMS provider could call in and say, I'm bringing in a patient, and be ready for that patient. And guess what? No one in the ED was ever ready for that patient across the country. So then we really decided that we needed to have stroke education for the nurses as well as the patients, neuroimaging, and the support of the hospital. And this is key in particular as you grow your programs for IA therapies and for providing comprehensive services. I'm going to talk about that in particular. So then the American Stroke Association got together with the Joint Commission, and they developed their very first stroke certification. I remember being around. I was part of that process. It took us a year to get ready for that visit. It was a one-day visit. It was very stressful. But we were able to earn our certification, and now there are actually over 1,200 primary stroke centers across the nation. I'm just going to mention in Maryland we have 43 primary stroke centers and 5 comprehensive stroke centers, which will really provide an example of some of the problems that we're having in rapid identification of a patient who should be transferred to a comprehensive stroke center. So really, what were their goals? Their goals were to increase public awareness of signs and symptoms of stroke. We really have not been successful with that. We still have less than 5% of eligible patients recognizing that they have symptoms and they need to go to the emergency room. I had a patient in the ED the other day. I feel like now I'm being Hillary Clinton. I don't mean to do that. But I usually walk, so I was just making a point. Came into the emergency room, and he said, I don't know why I'm really here, but his arm was weak from his elbow down to his hand, lasted around 10 minutes. His wife is a nurse. He came in, and so he went to our primary stroke center where they did a CAT scan, and they said, oh, you probably, he had been camping, and he had been doing some other things, and they said, oh, you just have a sprain, because the symptoms weren't the traditional stroke symptoms. But really the keys were that it came on all of a sudden, the symptoms occur over minutes, and he was discharged home. So then his symptoms had a stuttering presentation. He went back to the same primary stroke center, and it was a nurse who said, why did you go home? Like, this is definitely a stroke. We're going to get a CAT scan. We're going to initiate a stroke protocol. That's what they did. They ended up showing a pretty significant stenosis with the CTA of the M1. So he was transferred down to the University of Maryland, and we got a huge clot out of his M1. And so he was very fortunate. I saw him in the clinic this week, and he has zero deficit. So he's going to be returning to work as a construction estimator. So don't underestimate the skill of the nurse in your ED to really say about a patient, this is a stuttering presentation. You start in the primary stroke center. He got fantastic care that second time around, and he went where he needed to go. But we still have a long way to go with public health awareness about these patients and the need to give IV TPA. In the state of Maryland, I'm going to tell you, we have pockets of ED physicians who will say, I just don't believe in TPA. I swear. When I go across the country, I hear in certain EDs, TPA isn't effective. So you would think that in 2016 that would not be an issue, but the Joint Commission and the American Heart, as well as CMS and regulatory agencies, are coming down hard on those physicians. And if you have a physician like that in a hospital, what I'm seeing is that they lose their credentialing and they're not allowed to practice in that ED if they will not administer TPA. So now we're having some regulatory information to share with our teams that this is something that's mandatory. So then we have some of the stamps here, and as you know, the CT acquisition is actually 20 minutes, and the CT interpretation is a total of 45. So I have those reversed. But now, starting in July, for comprehensive stroke centers, you probably will need to get your CAT scan in 10 minutes, and it needs to be read in 20. So that's coming down the pike. So a comprehensive stroke center is really set up to really be able to take care of those patients beyond TPA. Also in July, I think you're going to see that your TPA times are going to be required to be 45 minutes. So they arrive at your hospital, and then the TPA will have to be administered door to TPA time of 45 minutes. Now that's for primary. Then they thought, wouldn't it be great if we had a comprehensive stroke center system? That again came out of the metrics of the Brain Attack Coalition. And the idea is that you would have a tiered system of advanced stroke systems that would have 24/7 services that you could provide the patient. And some of those things that we talk about, and this quote is directly from Alberts, which is used by the Joint Commission, CMS, as well as the American Heart and the American Stroke Association. The complex stroke patient often requires advanced diagnostic and treatment procedures directed by specially trained physicians and other healthcare providers. What we're talking about are healthcare centers that aren't better than primary stroke centers, just different. I think the idea that the Joint Commission wants to get out there is that the primary stroke center is as important. They are the first cog in the wheel of recovery. But when you have a patient that might meet certain ICD codes for stroke, you really need to seriously consider sending them to a comprehensive stroke center. And so some of those patients would be the ICH and SAH patient. Saw a patient in the clinic this week who was 46 years old, African-American man, left-handed. He was at home with his 7 children, and he just had the worst headache of his life. His eyes felt blinding. He started to vomit, nausea. So we all know what that means. So his significant other called 911. He went to a primary stroke center. They saw the bleed. He had an intracerebral hemorrhage. He immediately was transferred to a comprehensive stroke center, which happened to be ours. He had mass edema within 24 hours. Sometimes it takes up to 48 hours, and had an evacuation and had a decompressive hemicraniectomy. What I want you to know is that those procedures really are, you're going into it with the idea that this patient may be dependent, requires skilled nursing care, and it's not a solution for every single patient with a large malignant stroke. However, if you have someone who's really young and you can do it early in a comprehensive stroke center where you have neurosurgeons who can perform the procedure routinely and very rapidly, and you can have neuro-trained ICU nurses, then the recovery can be very good. When I saw him in the clinic, he had a little bit of a right-left limp. He was walking with a cane, and he also had a profound dysphagia, unfortunately for him. And so he's now seeing speech therapy, went to rehab. But that is exactly the kind of patient that you should consider sending to a comprehensive stroke center. Those patients who need an aneurysm repair, you usually are not going to see the skills in most centers that you need in order to do that.